Okay, so today we're going to be talking about valvular heart disease, and really this talk is geared towards your board's exam. So we're going to be focusing on things that are going to help you with your test. Our objectives are to review the basic cardiac cycle, and that's really the foundation. For you to understand valvular heart disease and make that diagnosis, you really have to understand the cardiac cycle. We're going to identify sort of the key historical and physical findings in valvular heart disease. And then we're going to choose a couple of the most commonly tested valvular problems and talk more about them specifically in terms of etiology and management. But I will say that most of these tests really want you to identify the lesion itself, so making the diagnosis, and I would say that's the most important thing. Sometimes, the test questions may be kind of two-pronged, where you might have to identify the lesion and then something in addition to that, like a management question or something like that. But I would say 80% of the time, if you can get the diagnosis, you're in good shape. And then on top of that, even if it is a kind of a multi-pronged question, you're going to be able to narrow it down for yourself if you at least get the diagnosis. So that's what we're going to be spending most of our time dealing with today. And then, of course, obviously we hope that this lecture helps you on your test. So this is a sort of a framework approach to heart murmurs in adults. And we're going to be kind of referencing this framework throughout the presentation, and sort of just a nice way of organizing the differential diagnosis for valvular heart disease, kind of separating things out in terms of kind of the timing. So which part of the cardiac cycle are you hearing this murmur? And then the shape of the murmur. And then from there, kind of is it on the right side or the left side of the heart? So we'll kind of be using this as our guide throughout the talk. And then, as I mentioned, we're going to pick a handful of these that are commonly tested, including aortic stenosis, hypertrophic obstructive cardiomyopathy, mitral regurg, mitral valve prolapse, tricuspid regurg, and then on the diastolic side, aortic regurg and mitral stenosis. And we'll talk about them a little bit more specifically. Okay, so cardiac anatomy, the basics. There are 4 valves. The mitral valve and the tricuspid valve, the aortic and pulmonic valves. And you'll notice that those are paired up together, and they're paired up because they really are sort of the right and left counterparts of one another. So both of those paired valves are going to be open at the same time. They're both going to be closing at the same time. And generally, pathology involving one of them is going to give you a similar sound, similar type murmur for both of them. So we're going to pair those up together. The mitral valve separates the left atrium and left ventricle. The tricuspid valve separates the right atrium and right ventricle. The aortic valve separates the LV and aorta. And finally, the pulmonic valve separates the RV and pulmonary artery. So the foundations are really important. Okay, so in terms of the cardiac cycle, during systole, the ventricles are contracting at that time to eject blood into the 2 circuits. The LV is going to inject blood into the aorta, and the RV into the pulmonary artery. And so obviously, in order for that to happen, the aortic and pulmonic valves should be open. They should be wide open. The gate should be open to allow blood to flow through them. At the same time, the mitral and tricuspid valves should be closed, because you don't want to eject blood backwards into the atrium. You want all of the blood to go forward into the aorta and into the pulmonary artery. During diastole, the exact opposite is true. So at that time, the ventricles are relaxing and accepting blood from the atria. So, as you might imagine, the mitral and tricuspid valves should be open at that time to allow blood to flow across them into the ventricles. And then the pulmonic and aortic valves should be completely closed during that time. So the beginning of systole is kind of marked by closure of the mitral and tricuspid valves. You get isovolumetric contraction of the ventricles, and the pressure then exceeds the pressure in the atria, and that triggers closure of the tricuspid and mitral valves, and that creates S1. And then at the end of systole or beginning of diastole, once the pressure in the aorta and pulmonary artery exceed the pressures in the LV and RV, then the pulmonic and aortic valves close, and that creates S2. So in between S1 and S2 is systole. In between S2 and S1 is diastole. It's very important to understand kind of where you are in the cardiac cycle. That's 80% of it. If you could figure out, okay, as you're listening to the patient's heart, which one, what is S1, what is S2, in between is systole, and then in between S2 and S1 is diastole. It's very important. There are two basic types of valvular lesions. Okay? You can have stenotic lesions or regurgitant lesions. And so in terms of stenotic lesions, this really affects valves that are open, should be open. The gate should be wide open. And there's some lesion or some issue, calcification or whatever, that's causing blockage of the gate of that valve. And so as the blood is ejecting through it, it's going to create turbulence. And that turbulence is going to create a murmur. And eventually it's going to create problems for patients. On the other hand, regurgitant lesions affect valves that should be closed. When the valve is completely closed, no blood should be flowing through it at that time. But if there's an issue where the valve is leaking, then you're also going to create turbulence at that time, create a murmur, and then also additional heart problems for the patient later on down the road. Each of the four valves can be stenotic or regurgitant. So that's an important concept. So each valve can cause a murmur, each valve can have a problem which will cause a murmur in systole or diastole. So in terms of the aortic and pulmonic valves, which we'll pair together, again, they should be wide open in systole. So a stenotic lesion of the valve during that time will create a murmur in systole. So aortic stenosis, pulmonic stenosis will create a murmur in systole. Whereas they should be closed during diastole. So that's where you get, if you have a regurgitant problem with those valves, aortic regurg or pulmonic regurg, you'll get a murmur during diastole. The opposite is true for the other two valves. They should be open in diastole because that's when the blood is flowing from the atria to the ventricles. So if there's a partial blockage of those valves during that time, stenosis, you're going to get a murmur during diastole. And if they should be closed during systole, so if there's a regurgitant lesion involving those valves, it will create a murmur in systole. Does that make sense? So each of the valves can create a murmur in systole and in diastole, depending on what type of lesion it is. So there are 5 key physical features that they loved. These are all clues when you're taking your test of which valve is problematic. They're going to tell you about the timing of the murmur, whether it's in systole or diastole. They're going to tell you the shape of the murmur, whether it's crescendo, decrescendo, whether it's holosystolic. And actually, let's go back to that for a second. So there's 2 basic shapes for systolic murmurs and 2 basic shapes for diastolic murmurs. In terms of systolic murmurs, a crescendo, decrescendo murmur has shape to it. So it kind of goes, it crescendos and then it decrescendos, exactly as the name implies. It's also known as a diamond-shaped murmur. Okay, so this sounds like whew, whew, whew. Contrast that with a holosystolic murmur, which keeps the same intensity all the way across. It's also known as a flat or plateau-shaped murmur. It sounds like this. So, versus. On the other side of things, in terms of diastolic murmurs, there are 2 flavors of diastolic murmurs as well. There are decrescendo murmurs and then decrescendo crescendo. So decrescendo murmur will sound like this. Starts off loud and then it trails off. Whereas a decrescendo crescendo murmur, it gets louder towards the end. There's something called presystolic accentuation. And that's what separates that from the decrescendo diastolic murmur. So it really sounds like this. So it's actually more of a rumbling sound. So it's a whoop, whoop, and that's the key, is it gets louder right at the end. Whereas the decrescendo murmur is whoop, whoop. Okay, so those are the shapes of the murmurs, and there's 4 basic shapes. Location is important, and by location, they're referring to part of the chest wall that you're best hearing this murmur. And then radiation pattern is important. Some of these things are so, they're such buzzwords on exam, and we'll get to it, but if you hear a certain type of radiation pattern, you automatically know what murmur or what valvular lesion they're talking about. We'll get into that. And then maneuvers really trips people up a lot, and they love to test on maneuvers. We'll try to make it easy to understand. So let's go over these things. So in terms of timing, again, is the murmur happening in systole or diastole? And test questions will often give you this information. They'll just simply say there's a systolic murmur or a diastolic murmur. Or they might get cute and just say there's a murmur heard between S1 and S2, but you already know that's going to be a systolic murmur. And the reason why this is important and up front and center is because it allows for immediate dichotomization of the differential diagnosis, as you guys saw from the framework. If you know whether the murmur is a systolic murmur or diastolic murmur, it immediately cuts your differential into half. So it's very important. Next, shape. So we already kind of went through the sounds. There's two shapes to systolic murmurs, two shapes to diastolic murmurs. And again, your tests will often give this information. They'll say there's a decrescendo diastolic murmur or a holosystolic murmur. And this allows for further sort of dichotomization and narrowing of the differential diagnosis. So, for example, if you know that the murmur is diastolic and you know that it's decrescendo, well, that narrows it down to only two possibilities, aortic regurg or pulmonic regurg. Location is important. So the two basic locations, you'll hear people refer to, a sound, a heart sound that you best hear over the base of the heart. That's referring to kind of the area of the heart near the pulmonic and aortic valves. It's closest to the clavicles. And then the apex is kind of towards the nipple. There's four kind of specific locations that you should be aware of. The aortic valve kind of hangs out around the second intercostal space at the right upper sternal border. And by the way, again, test writers love to give you these clues. So if they mention anything about the second intercostal space of the right upper sternal border, you should immediately be thinking about aortic valve pathology. The pulmonic valve is the second intercostal space left upper sternal border. Tricuspid valve is the left lower sternal border. Sorry, my voice got very loud there for a moment. And then the mitral valve is apex. So that's the about the fifth intercostal space, mid-clavicular line. Okay? So these are very important to commit to memory because, again, they like to give you these clues. Radiation pattern, as I alluded to earlier, you can just take it to the bank. If they tell you that there's a murmur that radiates to the carotids or the clavicle, that's aortic stenosis. If they tell you that there's a systolic murmur that radiates to the axilla, that's mitral regurg. End of story. So good to kind of commit these to memory. Okay, so you guys ready to talk about maneuvers? So this is really what trips people up a lot. And hopefully we can sort of break it down and kind of make it easier to understand. Well, the first thing is patient positioning. So if they tell you about a murmur that's best heard in the left lateral decubitous position, they're trying to get you to identify mitral stenosis. You should think about mitral stenosis. If they tell you that the murmur is best heard with the patient leaning forward, that's aortic regurg. Okay, so now for the maneuvers that people hate to think about, but we're going to make it easy. Okay, so all maneuvers are doing or attempting to do is to manipulate blood volume. Okay, that's all that was standing, squatting, Valsalva, all that stuff. The bottom line is it changes the amount of blood flowing across a lesion. And the main concept you have to understand is that most murmurs are going to increase in intensity with more blood flow across the lesion. Okay, it's sort of the garden hose analogy. So if I have a garden hose, okay, and I've got my thumb over the nozzle, partially blocking it, and I go and I turn up the faucet halfway, well, as the water's coming out of the garden hose, it's going to run into my thumb, it's going to create turbulence, and it's going to create a sound. So it's going to sound like tss. What would happen if I didn't move my thumb and George went and he turned up the faucet full blast? What's going to happen to the sound? It's going to get louder, right? The same is true in the heart. So as you have a fixed lesion, a murmur, that's creating a murmur, it's going to get louder if more blood flows across it. That's all it is. And then conversely, if you decrease the amount of blood flowing across a lesion, then it's going to decrease in intensity. There are two exceptions to this, and we'll get to those in a bit. Okay, so how do you manipulate blood volume across a lesion? There are three basic ways. Okay, so you can alter blood return to the right heart, you can alter blood return to the left side of the heart, and you can alter afterload. Okay, so let's talk about each one of these individually. So how do you alter blood return to the right side of the heart? Well, that's inspiration. So if you have the patient take a breath in, what happens is their intrathoracic volume increases, so pressure drops, and so as pressure drops, now more blood is going to go, it kind of creates a vacuum, and more blood is going to go towards the right side of the heart as a result. Now, a lot of people think, well, by definition, if you have more blood going to the right side of the heart, wouldn't you also get more blood going to the left side of the heart? And the answer is no. I mean, eventually, the answer is yes, eventually that's true, because what's on the right must go to the left. But in that moment when they're taking a breath in, what also happens is that because the pressure drops, the pulmonary vasculature dilates. And so you get pooling of blood within the pulmonary circuit, so the left side of the heart actually doesn't get an increase in blood flow at that moment. So it isolates the increase in blood flow to the right side of the heart, which is really critical. If you're listening to a murmur and it gets louder when the patient takes a breath in, that's called Carvalho sign, and that indicates that the murmur is coming from the right side of the heart. It's a really powerful sign, and can help you identify right and left-sided lesions, the last kind of part of our framework. Any questions about that? Okay, so next we're going to talk about altering blood flow to the left side of the heart. Okay, so how do you increase blood volume to the left side of the heart? This is things like leg raise or going from a standing to a squatting position. That's going to mobilize all the blood that's in the lower extremities back to the heart. And of course, it's going to go from right to left. But inspiration is not part of this, so there's no pulmonary vasodilation or anything, so it will go to the left side of the heart. To decrease blood volume, you can go from a squatting to standing position, or you can have the patient Valsalva, which creates an increased intrathoracic pressure, so it prevents blood from flowing back to the heart. Those are the ways you do it. Now, all murmurs, as we talked about, will increase with increased blood volume, except for, these are the two exceptions, mitral valve prolapse and HOCM, hypertrophic obstructive cardiomyopathy. And then all murmurs will decrease with decreased blood volume, except for the same two murmurs, or lesions, mitral valve prolapse and HOCM. Now, if you want to memorize that for the test, that's great. You'll do fine. But just like anything else in medicine, it's always better to understand kind of the idea or the mechanism behind it. So let's talk about HOCM first. So if you can all imagine, my right hand is the left ventricle, and my left hand is the septum. Okay, so here's the cavity, the LV cavity. Here's the aorta. So when the LV contracts, the blood's going to flow this way into the aorta, and here's the valve up here. So this is actually not a valvular lesion, HOCM, but it's commonly, they like to trip you up, and it's commonly tested, so we should definitely talk about it. But there's the outflow tract there, okay? So if in somebody who has hypertrophic obstructive cardiomyopathy, they have septal thickening, okay? So that compromises, that further narrows that LV outflow tract, and that's what creates turbulence and creates the murmur. So if you can imagine, I do something to increase LV volume. Let's say I go from standing to squatting, and it increases LV volume. What just happened to the outflow tract? It got wider, it got bigger, exactly. So the murmur decreases in intensity. That's the reason why that happens. Now, mitral valve prolapse, it's a bit of a misconception that the murmur intensity increases or decreases with maneuvers for mitral valve prolapse. I almost hesitate to say that because I think the test writers are also probably going to be operating under this misconception. But really what it is it's the click and the murmur move in systole. So it either starts earlier or starts later in systole. And here's how that works. So imagine, again, my right hand is the LV, and imagine my left hand is the valve. So here are the valve leaflets. And what connects the valve leaflets to my fingers? What are my fingers representing that connects the valve leaflets to the LV? Chordae tendineae, exactly. And that's the problem in mitral valve prolapse. These become lax through, from myxomatous changes or from Marfan, connective tissue diseases or ischemia or something. And so these become lax and kind of parachute into the left atrium, okay? So, and that allows blood to basically flow through it. It doesn't pull the valve down taut. So what do you think would happen if my LV volume increased? It's going to pull those chordae tendineae along with it, and it's going to pull the valve down shut. Okay, so no MR, no regurg. When I start to contract, it's going to take longer to reach that critical volume at which the chordae tendineae then become lax and parachute into the left atrium, okay? So the murmur happens later in systole with increased blood volume. So you can think about it, they're going to say that the murmur decreases in intensity. It's really that it occurs later in systole. And the same is true, or the corollary is true. If I start off with a really small LV volume from having the patient Valsalva, well, now it doesn't take much to reach that critical volume at which the chordae tendineae become lax and parachute into the left atrium. Does that make sense? So the murmur is going to happen sooner in systole with lower blood volume. Okay? Any questions about that? That's a good point. I think that there are several of the chordae, so if one goes out, I mean, unless you have complete rupture of all of them, which I've never heard of, I suspect that the others will kind of compensate in a way. But that's a good question. It's a good question. Any other questions before we move on? Okay, so then the last sort of maneuver is manipulating afterload. So how do you increase afterload? Well, this is kind of the hand grip. So you have the patient make a fist with both of their hands and squeeze, or you can put blood pressure cuffs on both arms and blow them up, and that will increase afterload. And as you might imagine, if you increase afterload, that's going to increase the pressure in the aorta. So murmurs like aortic regurg, where it's reliant on a gradient from the aorta back to the LV. If all of a sudden that gradient increases because of an increase in aortic pressure, you're going to get more regurg, and you're going to get more blood flow and a louder murmur. Does that make sense? And then mitral regurg, blood will go to the path of lesser resistance. So if you have the LV squeezing, blood can go either out the aorta like it's supposed to, or in somebody with mitral regurg, it can go backwards into the atrium. So if all of a sudden you increase the resistance through the aorta by increasing afterload, well, more blood is going to then go back into the left atrium. So mitral regurg gets louder. So those are the two that they commonly will associate with alterations in afterload. Okay, so if your test mentions, hand grip, think, the murmur gets louder with hand grip or with blood pressure cuffs, think aortic regurg or mitral regurg. There are some other key physical features and buzzwords for these tests. So aortic stenosis is going to be associated with some peripheral pulse findings, so pulsus parvus et tardus, or a weak and delayed peripheral pulse. If you see that on the test, you're done. It's aortic stenosis. If you see other peripheral pulse manifestations, like there's tons of eponymous findings for aortic regurg, like Corrigan's pulse or Waterhammer pulse or Quincke's pulse. Anybody know what Corrigan's pulse is? That's the Waterhammer pulse, yeah, the radial. But it's the same idea. So they're all manifestations of a wide pulse pressure. By the way, if you see a blood pressure of 110/35, think aortic regurg on these tests. But it's all a manifestation of a wide pulse pressure, all of these eponymous findings. So Waterhammer pulse is the bounding radial pulse. Corrigan's is a bounding carotid pulse. Anybody know what Quincke's pulse is? Yeah, exactly. So you get nail bed pulsations. Yep. So if you were lucky enough to have any of those clues, you're done. Aortic regurg. Tricuspid regurg may be associated with something called Lancisi's sign, which is CV fusion. So the jugular venous waveform, there's an A wave, a C wave, a V wave, and then in between the C and V wave is an X descent, and then after the V wave is the Y descent. And because of the regurgitant lesion, you basically, when the RV squeezes and all that blood goes back into the right atrium, it actually goes right up into the neck, and you can see a big CV fusion wave. So if they mention that there's a CV fusion wave on exam while they're giving you this test question, then you've got to think about tricuspid regurg. Mitral stenosis is almost always described as a rumbling murmur. So if you hear the word or see the word rumbling, mitral stenosis. If they tell you that there's an opening snap or describe what sounds like it could be an opening snap, also think mitral stenosis. Okay, so now we're back to our framework, and we're going to talk about some of these things kind of one at a time. So the first one we'll talk about is aortic stenosis. So the typical patient will be older, with degenerative changes. Usually patients are going to be in their 70s or 80s, or younger patients with bicuspid aortic valves. Okay, so this is a congenital problem that people are born with. Arnold Schwarzenegger had a bicuspid aortic valve, and that's why he had his aortic valve replaced at age 50 or however old he was. He was young. And so those are kind of your two demographics. So if the question describes a younger patient with bicuspid aortic valve, you should automatically be thinking about aortic valve problems, either stenosis or regurgitation. These patients will present with angina, syncope, dyspnea. And on exam, as we've already talked about, you're going to get a crescendo-decrescendo systolic murmur at the right upper sternal border. That's where the aortic issues tend to be. And then there's radiation to the neck and clavicle in bold, because again, if you see that, you're done. Soft S2, S4 gallop because of the concentric left ventricular hypertrophy that happens. And then pulsus parvus et tardus, again in bold, because these are pathognomonic for aortic stenosis. So these are good things to commit to memory, because if you see them on the test when you're flying through and you're sweating, and you're like, man, I'm getting all these wrong, you see that, you're in good shape. Other clues would be LVH or left axis deviation on EKG. Okay, so echo is going to be helpful for sort of characterizing the severity of the lesion. So these are just, you're just going to have to memorize these in terms of kind of the aortic jet velocity and then the mean gradient. And probably they'll just want you to know maybe what severe is. So maybe just remember 4, so 4 and 40. And then aortic valve area used to be part of the criteria, but it's no longer. But in general, severe AS is associated with an area of less than 1 centimeter squared in severe AS. Okay, so in terms of management, aortic valve replacement, we'll skip down to the bottom of the slide. Symptomatic severe AS, surgery. Asymptomatic severe AS, if they're going to have another valve replaced or a bypass surgery, you're going to be in there, you might as well replace their severe AS, even though it's not symptomatic. If they have LV dysfunction, you should repair the valve. Otherwise, it's serial echo. So it's yearly in patients with severe AS that are not symptomatic or don't otherwise meet criteria, every 1 to 2 years for moderate AS, and every 3 to 5 years for mild AS. Any questions about aortic stenosis? Okay, the other one, as I alluded to earlier, that they like to sort of trip you up with, or that could sound a lot like aortic stenosis, is hypertrophic obstructive cardiomyopathy, which we've already talked about a little bit. This is going to be young athletes. Okay, other people can get it as well, but the prototypical patient, if you see a young athlete presenting with or passes out a basketball, it's classic for HOCM. They usually present with dyspnea, chest pain, syncope. There may also be another clue of family history of sudden death, because this is a hereditary condition. On exam, you're going to hear that familiar crescendo-decrescendo systolic murmur. The clue, or the nice distinction between it and AS, is that it's not going to have any radiation. There will not be radiation to the neck or clavicle. You might also hear an S4 gallop in this, just as you would with AS, for the same reason. You get hypertrophic, or you get concentric hypertrophy. And the other distinguishing characteristic is that the carotid upstroke is going to be brisk, whereas in AS it's going to be weak. So that's a big clue. And then they love to give you the sort of maneuver with HOCM, and we already talked about this. So with maneuvers that increase blood volume to the left side of the heart, you're going to get a decrease in the intensity of the murmur, which is unlike all other murmurs, except for MVP, although we talked about that being a misconception. And then the intensity is going to increase with reduced blood flow. It's the only, pretty much, if you see a murmur that's similar to AS, but it does the opposite of what you'd expect with these maneuvers, then think HOCM. And then you might also see LVH, LAD, and prominent Q waves on EKG. Management, you only really treat HOCM if it's symptomatic. Pharmacologic treatment, you're really just trying to improve diastolic filling time, so it's beta blockers or verapamil. I'm not sure why verapamil is the calcium channel blocker of choice, but it is. And so those two, you think about those two for HOCM. And then in patients who are still having symptoms despite medical therapy, you think about non-pharmacologic treatment, and the two options would be surgery, a myectomy procedure, or alcohol septal ablation. So alcohol is kind of toxic to the myocytes, so they go in there and they squirt some alcohol along the septum, and then that basically causes it to melt away a little bit, and so it relieves that outflow tract obstruction. Make sense? Any questions about Welcome. Okay, next up is mitral regurg. So the question stem will include patients, well, first of all, you can get it from degenerative changes. Patients might have infective endocarditis. So endocarditis causes regurgitant lesions. And so if the question stem includes patient with endocarditis, think about TR, MR, AR. You can get secondary MR from ischemia or dilated cardiomyopathy, so that's also known as functional MR. Have you heard of that? Where basically the valve itself is not problematic, but if the LV dilates out, that starts to dilate the annular ring of the valve, and basically the leaflets won't touch each other when they can't co-op properly. So you get functional MR as a result. Your exam will include a holosystolic murmur over the apex with radiation to the axilla, bolded because if you see that, it's MR, period. You might also hear an S3 gallop with MR. Why? So S3 gallop occurs in volume overloaded states, and so if you have a bunch of regurgitant volume going back to your LA, when it goes back to the LV, you have this big bolus of blood dumping into the LV, and it's going to make that S3 sound when it enters the left ventricle. So that can be a clue that you're dealing with mitral regurg. And then, of course, as we talked about, afterload. So increasing afterload is going to increase blood flow through that valve, and it's going to increase the murmur. Okay, so there's pretty limited medical management for MR. Really, your only option is surgical repair when it's severe enough, and then your options are kind of repair, clip, replacement, and this is fairly new, probably too nuanced for this lecture and for this exam. Okay, so mitral valve prolapse. So very common form of valvular heart disease, and the prototypical patients are going to be young women who present with chest pain, palpitations, lightheadedness. The other population you should think about will be connective tissue disease, so Marfan syndrome. So if you see that, you should be thinking about MVP. The exam, there will be a mid-systolic click, and again, if they give you this information, you're done because this is the only condition associated with a mid-systolic click. And then that's followed by a holosystolic murmur over the apex, and it occurs late in systole. The first time I ever heard an MVP murmur, I thought I was listening to a diastolic murmur because there's S1, and then a pause, and then the murmur. Because you don't always hear the click, and if you hear the click, you might confuse it with S2. So you hear the S1, pause, and then a click murmur. And the first time I heard it, is this a diastolic murmur? And then I had to listen a bunch of times and realize that it's a systolic murmur. But it's late in systole. It's really the only murmur that happens that late in systole. The intensity decreases with increased blood flow, as we talked about. And really, again, it's really the click and the murmur occur later. That's the truth of the matter. Intensity increases with decreased blood volume. Okay, so tricuspid regurg. Think about it, and if they tell you about a patient who's an IV drug user who's presenting with a heart murmur, you should immediately think about TR. You can also get secondary forms of TR from pressure overload on the right side, pulmonary hypertension, dilated cardiomyopathy that's affecting the RV. For the same reason you get MR, functional TR. You're going to hear a holosystolic murmur over the left lower sternal border, and then you'll see Lanchysi sign in the neck. And then again, just like all other right-sided murmurs, the intensity will increase with inspiration. Make sense? Any questions about TR? Okay. Management is really aimed at the underlying cause, whether it's pulmonary hypertension or cardiomyopathy, RV dysfunction. You almost never perform surgery. Really, the only times I've seen the tricuspid valve replace is in drug users who may have the tricuspid valve is kind of the nidus of infection, and so it's more about removing that nidus of infection than it is about giving them their functional tricuspid valve back. A lot of people say you don't even need a tricuspid valve to, and you really don't. So again, surgery is rarely performed in this population. Okay, so now on the diastolic side, so we'll talk about aortic regurg and then mitral stenosis, and then we'll spend the rest of the time kind of going over some practice tests and seeing if you guys can identify the valve lesions. So let's talk about aortic regurg. Again, degenerative changes, so older patients or young patients with bicuspid aortic valves can get aortic regurg. Again, infective endocarditis, as we mentioned. And then the ones in bold here you should be aware of. So just like with MVP, patients with Marfan's can get aortic regurg because they get aortic root dilation from their connective tissue disease. Patients who have had aortic dissection can have concomitant aortic regurg. And then patients with syphilis, they get aortitis and can get dilation of that root that will cause aortic regurg. So if you see any of that in the question stem, you should think about aortic regurg. Your exam will have a decrescendo diastolic murmur over Erb's point. So what's Erb's point? I know I mentioned earlier the aortic valve is up here, right upper sternal border. Aortic regurg is the one exception in that you may hear the murmur over the aortic valve area, but really the place you're going to best hear it is Erb's point because of where it radiates. And that Erb's point is the third or fourth intercostal space along the left sternal border. So this is where you're going to hear aortic regurg best. Okay? And then, again, many peripheral pulse findings, including Quincke's pulse that we talked about earlier. And then manipulation of afterload is really the maneuver that they will present if this is a case of aortic regurg, if they're going to present a maneuver. And the intensity will increase with increased afterload. How do you manage AR? Medically, it's mostly about afterload reduction, and then in symptomatic and severe cases, it's a surgical problem, and you fix it with surgery. If you have an asymptomatic patient with severe AR and LV dysfunction, that's another time in which you would want to repair the valve. And this doesn't say it, but obviously if they're going to undergo another surgery like a CABG or something like that, and they're not symptomatic but they have severe AR, I'm sure the surgeon will probably want to do the valve at the same time. Okay, mitral stenosis. They love testing about mitral stenosis. So almost always related to rheumatic heart disease. That's why we don't see it very much anymore. But you'll still see it in patients who grew up in developing countries where antibiotics are not as prevalent and their strep throat may have gone untreated. It will often present with AFib and embolic events. That's an important concept. Have you guys heard of valvular AFib? When they talk about valvular AFib, they're talking about AFib in a patient with mitral stenosis. They're not talking about AFib in a patient with AS or with MR. It's mitral stenosis. And the reason that it commands its own category and term is because for whatever reason, they are incredibly prone to clots forming and getting strokes and embolic events. So they can present that way. I saw a case a couple years ago of a 20-something-year-old woman who grew up in Mexico and came here, and she initially presented with TIA-like symptoms, went to the ED, sent her home, and then she came back the next day with severe flank pain and had an embolic event to the renal artery. And a bunch of other things happened. And she eventually, the diagnosis was made by echo, which is sad because all you had to do was listen right here, and you would have heard this beautiful rumbling diastolic murmur with an opening snap that was classic for mitral stenosis. And she perhaps wouldn't have lost her kidney, and she underwent a bunch of other tests, including bronchoscopy when she presented with hemoptysis, because they will often present with hemoptysis. So she developed hemoptysis and had bronchoscopy and had CTs and all this stuff. And all of that comes at a cost, not only monetary, but as repercussions for the patient. That's extra radiation for patients. Sometimes we do extra tests, or we just think, oh, let's just test them for all this stuff. Well, you should never think that way, because if you take 100 people off the street and you just test them, you run the same test on 100 people, some of them are bound to come back with positives. And then you're going to go down this rabbit hole, and more tests, tests beget more tests, and then they get a complication, and they end up on a ventilator, and it's bad news. Yes. Correct, right after S2. So the way it sounds is, so I'm going to do the murmur in diastole, and then it's going to run up into S1, and then you're going to hear the opening snap and the murmur again. So it's whoop, but up, whoop, but up, whoop, but up, whoop, but up. So the whoop is the murmur, and it gets louder right before S1. So whoop, S1, but up is S2, opening snap, murmur. So whoop, Systole is quiet, but a whoop, but a whoop, but a whoop, but a. Yeah, no problem. We actually, that same case, we presented, or we published with an audio and video, and you can, if you just Google my name and mitral stenosis, you'll find that video, and you can listen to it. The murmur is absolutely classic, has an opening snap. There's actually a phonocardiographic tracing. I bought a 1958 so you guys know what phonocardiography is? So this stuff here, these are phonocardiograms. So they're graphical representations of sounds of heart murmurs, and that's what they used to do before echoes. They used to take a phonocardiograph machine and record these patients' hearts. And I think it's great for teaching purposes. So I bought one, a 1958 Burdick machine. It was awesome. It was one Saturday night, I got the phonocardiograph, and I took it apart, and I opened the thing up, and it smelled like 1958. It was just crazy, like it had never been opened before. And so I'm looking at it, and I'm like, okay, so here's the box, here's the microphone that you use to record, but where do you get the readout? So I open up the instruction manual, and turns out that it's an EKG machine that spits out the sound. That creates the printout. And I'm like, oh man, I'm looking at the cord that connects to the EKG machine. It's like this big. There's no way that there's an EKG machine that this will hook up to now. So I said, okay, what can I do? So I bought an EKG machine from 1950, whatever. And so I've got these two, machines in my house, and they look like they could kill somebody if you didn't use them right. And so it was one Saturday night. I got everything. Oh, the other thing was that the battery that the phonocardiograph machine came with was this big mercury battery that they don't make anymore. And it came with the original battery, and so obviously it was dead. And so that was the other piece. And so I talked to a bunch of people, and I figured out that there's some equivalent alkaline battery or whatever. So I went and I got that. So I had all these pieces that in front of me, but I had no idea if they worked or not. By the way, the guy who sold me the phonocardiograph machine said he's not a doctor. He's not in medicine. He has no idea if this works. He just collects antique medical equipment. So good luck. So I was pretty confident though, because it looked like it had not been opened or used very much. And then so I hooked it all up. I made the sign of the cross, went with it, and I recorded my heartbeat with it. It worked. It was awesome. And so since then, that was probably 4 years ago or so. So since then, I've been using it to kind of record patients who have gallops, because sometimes it's hard to hear, is this an S3 or an S4? Where's this murmur in systole or diastole? So it's really nice for learners to be able to see they're getting both inputs, visual and auditory. So anyway, why did I start talking about that? Oh, so yeah, if you want to look that up, so we recorded it. We recorded the murmur with the phonocardiograph machine, and we had this student who was really good with computers, and he basically, so the phono strip is, you can see it, like maybe there's 6 or 7 beats, so you see the murmur and stuff, and then he had this cursor, and he overlaid the audio with it, so the cursor is going across the phono as, in a video format, so you're hearing the murmur as you're seeing it. So if you guys want to know what mitral stenosis sounds like, Google that. Google mitral stenosis plus my last name, and you'll come up with that publication. You'll be able to hear that murmur and see it. Okay, so the exam, low-pitched, rumbling, decrescendo, crescendo, diastolic murmur heard over the apex in the lateral decubitous position. Think mitral stenosis, loud S1, and an opening snap. You might also see LA enlargement, RVH, in patients with pulmonary hypertension. By the way, that's why they get hemoptysis, is because of the pulmonary hypertension that they develop. Management is sort of twofold. So as we talked about, AFib is a big deal in patients with mitral stenosis. They're really high risk for stroke and other embolic events, so you really want to anticoagulate them, period. And then the other piece is the valve disease itself. If they're symptomatic and severe, valvotomy, where they basically just kind of open up the valve, they'll create regurg doing that, but they'll at least relieve the stenosis, or they'll do a replacement. And then in asymptomatic patients, serial echo. Okay, so this will probably take 5 or 10 minutes, and then you guys can have a break. But I basically pulled out the physical exam section from the cardiology sections of a board review test book. And let's try to see if you guys can figure out what the valve lesion is based on the description and the buzzwords that we talked about. Okay, so the first one, cardiovascular exam reveals a point of maximal impulse that is laterally displaced. There is a grade 3 out of 6 holosystolic murmur at the apex with radiation to the axilla. An S3 is present. So tell me what the valve lesion is and what you identified in this question stem that helped you figure that out. Yep. Okay, so sounds like mitral regurg, and why? Yep. S3, yeah, awesome. Yeah, that's perfect. So that's mitral regurg. Okay, any questions about that? Okay, next one. Cardiac exam reveals an S4 gallop at the apex and a grade 3 out of 6 mid-systolic murmur over the base that accentuates with Valsalva maneuver. Yeah, Hocum. So who said that? Now you have to tell us why. Yeah, pretty much. That's exactly right. And so somebody walk us through the Valsalva thing. So what does Valsalva do, and why would the murmur increase with Valsalva? I hear a voice, but I don't see it. Ah, there it is. Okay. Awesome. Everybody get that? Sweet. Okay, so Hocum. All right, so grade 4 to 6 early systolic murmur that increases with inspiration and is best heard in the second left intercostal space without radiation to the carotid arteries. Nice. Why? Yep. So I heard inspiration. So it increases with inspiration, which narrows it to the right side of the heart. So we're talking about a right-sided heart lesion. It's in the second left intercostal space, which, as we know, is a pulmonic valve area. That's your second clue. There's no radiation to the carotids, because otherwise you might think, is this AS, by the way, it's not common that a pulmonic stenosis would be grade 4 out of 6, because right-sided murmurs tend not to be as loud as left-sided murmurs because it's a lower pressure system. Having said that, this person may have long-standing pulmonic stenosis and might have RV changes and increased pressures and such that the RV pressures become like the LV. But it's funny because it's the only one with a 4 out of 6 or louder murmur, and it's the one that it's a right-sided lesion. But anyway, you guys are 100% right. So it's a systolic murmur that increases with inspiration, second left intercostal space of pulmonic stenosis. Nicely done. Next one. Cardiac auscultation demonstrates an irregular rhythm, a loud S1, normal S2, and an extra sound heard after S2 near the apex. A low-pitched diastolic murmur is heard following the extra sound. Mitral stenosis, yep. And what are your clues? Irregular is your first clue, because they often present with AFib. Remember that. There's a loud S1. If they tell you there's a loud S1, it's going to be mitral stenosis. This extra sound after S2 is what? Opening snap, low-pitched diastolic murmur. Boom. These are all word for word from board's exam, prep book. So this is exactly what you're going to be seeing, I hope. But in general, that's what these buzzwords are going to be, these test questions are going to be littered with these buzzwords that will help you figure out what the lesion is. So mitral stenosis, good job. On physical exam, blood pressure is 150/40. Carotid upstroke is brisk and collapses quickly. There's a grade 2 out of 6 early systolic murmur noted at the second right intercostal space. A grade 3 out of 6 high-pitched decrescendo diastolic murmur is noted over Erb's point. There's evidence of nail bed pulsation. Aortic regurg, but there's 2 murmurs. So aortic regurg often, a lot of people don't realize this, but it actually, people think it's just a diastolic murmur, but there's a diastolic murmur and a systolic murmur. Anybody know why? So good thought, good thought. It causes a flow murmur as well because it's like the garden hose analogy. So even though the aortic valve is opened up, there's no stenosis of the aortic valve, because of that regurgitant volume, now you have this huge volume of blood that's going back through the aortic valve, and so it creates a functional sort of AS-type murmur. So there's a systolic component to it as well. So good. You guys clued in on what is this? Wide pulse pressure. So this is they're describing Corrigan's pulse there, and then the systolic flow murmur, high-pitched decrescendo diastolic murmur, Erb's point, Quincke's pulse. Nicely done. Any questions about that? Okay. Cardiac exam reveals a sustained apical impulse, normal S1, and a single soft S2. An S4 is present. There's a grade 3 out of 6 early onset systolic, late peaking murmur that is heard best at the right upper sternal border and radiates to the left carotid artery. Carotid pulses are delayed. Yep, aortic stenosis. Good. A grade 3 out of 6 late systolic apical murmur is heard that radiates toward the left axilla. Moving from a squatting position to a standing position increases murmur intensity. What did you say? Yeah, so mitral valve prolapse with mitral regurg. This is, again, the intensity of the murmur doesn't change, but this is word for word from a review book, so I went with it, because you might see that, because you guys know better. But yep, you're dealing with a late systolic apical murmur, radiates toward the left axilla, so you know MR is involved, and then squatting position, squatting to standing increases murmur intensity. So what happens when you go from squatting to standing? What happens to the volume at the left side of the heart? It decreases, exactly. Yep. Good, so both of them, mitral regurg and mitral valve prolapse. There's only a couple more. Cardiac exam reveals a loud S1, normal S2, and an opening snap. What is the answer already? Mitral stenosis. There's a regular rhythm with a grade 2 out of 6 holosystolic murmur at the cardiac apex, radiating to the axilla, and a low-pitched 3 out of 6 mid-diastolic murmur following the opening snap that accentuates pre-systole. So what else is there in addition to mitral stenosis? Yep, exactly. So regurg, stenosis. Yeah, I think the last one here. So cardiac exam reveals a grade 2 out of 6 holosystolic murmur at the lower left sternal border that augments with inspiration. Evaluation of the JVP reveals a single large pulsation. There are track marks present in the antecubital region of the arms. Yep. Exactly right. Nicely done. That's it. That's all we got. Questions? You guys can clap. Go ahead. Okay, now you can ask questions. Yeah.
So you said on one of your slides about HOCM that you only treat. I thought that was one of the.
So good question. So yeah, so that you can get, and the reason why that happens is not the narrowing of the outflow tract per se, but the conduction abnormalities that you can get as a result of the hypertrophy can affect the conduction system of the heart. So these patients can, go into different rhythms and can cause sudden cardiac death. So if you know a patient has HOCM, you may want to, carefully consider whether they should have like an ICD or something like that. And I don't know off the top of my head what the criteria would be for moving in that direction and pulling the trigger and putting in an ICD in a patient with HOCM. Maybe it's they wear an event monitor, and if there's anything funny, they do it. If not, maybe they hold off. But that's a really good question, and I would encourage you guys to explore the answer to that. Because again, I don't know off the top of my head when they do ICD. That's a great question. But it's a conduction problems that they get.
S3 and S4.
Yep. So S3 is going to occur right after S2, and S4 is going to occur right before S1. Okay, so an S3 is going to sound like this. So if, S1, S2, bup, 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 bup. And when you're listening, you know which one is S1 and which one is S2 because diastole is longer than systole, so it's going to be, the cadence is going to be bup, 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 unless somebody's tachycardic, but for the sake of this demonstration, so bup, bup. So an S3 is going to sound like this, bup, but up, bup, but up, bup, but up, bup, but up. The 3 is right after the 2, okay? An S4, on the other hand, is going to be but up, bup, but up, bup, but up, bup, but up, bup. It's right before S1. Does that make sense? Now, pathophysiologically, what's happening is the S3, as we talked about earlier, is that bolus of blood that's entering the dilated LV creates a sound. And that's that. When does that passive filling happen? When does that first bolus of blood enter the LV from the left atrium? Well, it happens in the very beginning of diastole. So S3 is an early diastolic sound. And it tends to happen in hearts that are big and floppy. And so in patients with dilated cardiomyopathy. So the myocardium thins out, the chamber size enlarges. So this is patients who have alcohol-induced cardiomyopathy or ischemic cardiomyopathy or adriamycin-induced cardiomyopathy, where their LV is big and floppy, and that initial bolus of blood creates a sound in early diastole. An S4, on the other hand, is right before S1. And what is right before S1? That's the very end of diastole. So what's happening at the end of diastole? So in the beginning of diastole, you get this passive filling, and then at the very end, what happens? Atrial kick and atrial contraction, exactly. And then that squeezes out more blood into a stiff myocardium, and that creates the S4 sound. So an S4 is associated with concentric hypertrophy, so things like aortic stenosis or long-standing hypertension that causes the myocardium to thicken up, and it has no problems in systole, so there's no systolic problems. All the problems are in diastole because it's a thick, sort of non-compliant ventricle. And it can squeeze really well, but it can't accept blood. So you get diastolic heart failure, and you get an S4 sound, whereas the S3 is big, floppy heart at the beginning of diastole. Does that help?
In terms of the sudden cardiac death or sudden death picture.
Well, I mean, again, there's so many factors to take into account. If there was a test question that you had in mind, we could kind of dissect it. But I mean, you're going to have to take into account history and exam. I mean, there are certain exam features that are going to be present in somebody with HOCM that wouldn't be present in the other conditions. There are EKG findings that will meet Brugada criteria that wouldn't be present in HOCM, or I can't remember the other one that you mentioned. But yeah, there's a slew of things, from everywhere from the history to the exam to the EKG that's going to help you sort of identify which one you're talking about. Other questions? Okay, cool. I always forget to mention this. If you guys are interested in physical exam stuff, I have a Twitter page, and I used to do it weekly. And so I'm going to create a website, actually, and I haven't posted in a little while. But I used to post videos of Lancisi sign or heart murmurs, things like that. So if any of this stuff interests you, check out my Twitter. I always forget to put my handle or username on there, but it's just basically my name, so it's @AndreMonsour. And there's some great sort of archived physical findings. I say archived, I've only been on it for like 6 or 7 months. But so if you look back, you'll see it. But the reason I haven't posted in a while is because I'm in the midst of creating a website that's going to have all of these physical findings in one centralized place on the website. So I'm working on that now. But yeah, if you guys are interested in this stuff, check out the Twitter action. All right, any other questions or anything? Okay. Thanks, guys.